So we are at 30 minutes past the hour, so let's get started. Wherever you are in the world at the moment, I'd like to say a huge welcome to you all and to our webinar today. My name is Natasha McIntyre, and I'm a clinician scientist in London, Ontario, and I was also part of the 2024 KDIGO Clinical Practice Guideline for the evaluation and management of chronic kidney disease. So, before we begin, I'd just like to run through a couple of housekeeping points. Firstly, that your microphones and cameras have been disabled for the duration of the webinar. This meeting is also being recorded so that it is available for on-demand use after the session. And during the session, if you could please submit any questions for speakers to answer during the Q&A, using the Q&A feature. We'll answer as many as we can. We've only got a small allotted time to answer the questions on air, but we will try and respond to the rest offline. And also, if you're having any technical difficulties, also use the same Q&A feature to submit any queries. So, this is the fourth in the series of 5 webinars celebrating the holistic approach to the evaluation and management of CKD and the new clinical practice guideline relating to this. Today, we will be looking at personalizing our approach with a focus on targeting the treatment for those people with diabetes and concomitant chronic kidney disease. Joining me today is also Dr. Ian de Boer, who is a professor of medicine and the director of the Clinical Research Unit in Seattle in Washington in the US. He was also one of the 2 co-chairs of the 2022 KDIGO Clinical Practice Guideline for the Management of Diabetic Kidney Disease. So, in terms of the agenda for this webinar, Dr. de Boer will be guiding us through a couple of interactive case studies, applying the guidelines to the individual case study. This will be followed by a short panel discussion addressing any questions raised through the Q&A feature, before we summarise and close. And in terms of looking at the learning objectives today, we hope that by the end of this session, you will be able to review the role of first-line therapies, such as RAS inhibitors and SGLT2 inhibitors, in the management of patients with chronic kidney disease. We hope that you'll also have an understanding of how standard of care therapies may be affected by declining eGFR and the presence of comorbidities, such as hypertension and type 2 diabetes. And that you'll be able to describe the additional risk-based therapies that are available for the management of chronic kidney disease and recognise when their use is appropriate. So I'd love to introduce you and hand you over to Dr. Ian de Boer, and he's going to take us through some interactive case studies. Ian, over to you.
Thank you so much, Natasha. Hello from Seattle, Washington. Good morning, and hello wherever you are in the world. It's really a pleasure to speak with you today about treatment of diabetes and chronic kidney disease. This is such an exciting area. We have great new evidence-based treatments that are available for people, and the combinations of treatments and individualization of those treatments begets a lot of questions. Happily, KDIGO and the Science Collected team have put together 2 interactive case studies for us today, and I will lead us through those cases. We will ask for your input via polling questions, so please get ready, and please do feel free to submit questions about the cases or other aspects of diabetes and CKD care through the question chat function so we can discuss them in the panel. I'll dive into our first case here, who we'll call Katherine. Katherine is a 61-year-old woman who was newly diagnosed with type 2 diabetes. At the same time, which is often common, she was also diagnosed with chronic kidney disease. She's already treated with a number of medications that you're familiar with that are evidence-based therapies, including metformin, tirzepatide, which is a dual GLP-1 and GIP receptor agonist, a low dose of the ACE inhibitor ramipril, and the statin rosuvastatin. These are her physical assessments and laboratory values. She is overweight with a BMI of 27 kilograms per meter squared. Blood pressure is at or near goal, depending on her individualized target, with a value of 121 over 78 millimeters of mercury. Her eGFR is low at 44 mils per minute, putting her in the G3B category, the KDIGO heat map, with a normal or high normal albumin-creatinine ratio of 28 milligrams per gram, and a hemoglobin A1C that most would consider at target less than 7%. So this is a fairly typical patient with new onset type 2 diabetes and concomitant chronic kidney disease. And this brings us to our first poll question, which is, based on her current evaluation and medications, would you initiate an SGLT2 inhibitor as well in this patient? And some of the features to point out here are that she does have type 2 diabetes, not type 1, that she has chronic kidney disease manifest primarily as low eGFR with a normal urine albumin to creatinine ratio. And I'd like to point out that by virtue of this, she is at risk both of progressive chronic kidney disease and cardiovascular disease events, and that our goals for care should be to personalize your care to improve those clinical outcomes. All right. So I can see lots of answers coming in. They're starting to slow down a little bit. And I will share that overwhelmingly people have said yes, that Katherine should start an SGLT2 inhibitor. Can I share those results? Perhaps, I'm not sure. Sorry, I'm toying with the technology here. All right. Good. So when evaluating the framework for prescribing in diabetes and chronic kidney disease, we'll come back to this diagram here, which is one that's been shared by a number of concordant guidelines, the 2024 CKD guidelines, the 2022 diabetes and chronic kidney disease guideline, and also a consensus statement between KDIGO and the American Diabetes Association. And it's important to point out that with the base of evidence that we have, there is widespread agreement across guideline groups about how to take care of people with diabetes and chronic kidney disease. So you can see here that lifestyle therapy is always considered an important foundation of care, including healthy diet, physical activity, smoking cessation, and weight management, and that there is now a widely agreed upon first-line set of drug therapy for most people with type 2 diabetes and chronic kidney disease, including the metformin, RAS inhibitor, and statin that Katherine was already treated with, and the SGLT2 inhibitor, which this audience appropriately identified was missing. So let's dive a little bit into the SGLT2 inhibitor recommendations in regards to this patient. So KDIGO, in its 2024 CKD guideline and 2022 diabetes and CKD guideline, have the exact same recommendation shown here in blue, which is we recommend treating patients with type 2 diabetes, chronic kidney disease, and this is of any manifestation, either low eGFR, elevated albuminuria, or both, who have an eGFR of 20 mils per minute or more with an SGLT2 inhibitor. It is a level 1A recommendation. That is, 1 is applicable to most patients, and A is a high level of evidence based on randomized controlled trials. So you appropriately identified that this patient should indeed, according to the guidelines, be treated with SGLT2 inhibitor. The KDIGO guidelines provide a number of useful practice points that help implementation of the recommendations. In this case, there are two highlighted here that are worth pointing out. So we recommend starting an SGLT2 inhibitor for people who have an eGFR of 20 mils per minute or more, because we have evidence for that range. We do not have evidence for what to do in terms of initiation when people have an eGFR less than 20. However, based on trials that started above 20 and continued when people went below 20, we do think that it's safe and effective to continue SGLT2 inhibitors should the eGFR slip below 20 mils per minute on therapy. And practice point 3.7.3 in the bottom left here also emphasizes that there is an expected hemodynamic reduction in eGFR with initiation of an SGLT2 inhibitor. It tends to be small, and is not necessarily associated with poor outcomes. It's part of the mechanism of effect, and SGLT2 inhibitors can generally be continued with dips in eGFR up to 30% or more. Summary, Katherine should receive an SGLT2 inhibitor, and I'm pleased that the audience appropriately identified that. All right, let's move to our second case, who we'll call Emmanuel. Emmanuel also has type 2 diabetes, diagnosed 3 years ago. He's 53 and has concomitant hypertension. He has recently diagnosed chronic kidney disease based on both albuminuria and eGFR, as you'll see. He's also already on a good group of medications. This includes metformin, the SGLT2 inhibitor dapagliflozin, the GLP-1 receptor agonist semaglutide, an initial starting dose of the ARB irbesartan, and atorvastatin, statin. And appropriately, you're reassessing his quantitative metrics, his labs. He has a BMI of 33 kilograms per meter squared. His blood pressure is probably not where most of us would consider an optimal goal, 134/82. His eGFR is modestly reduced at 56 mils per minute with an albuminuria, an albumin-creatinine ratio that is mildly elevated at 40 milligrams per gram. His hemoglobin A1C is 7.2%, and his serum potassium is within the normal range. So our poll question number 2, would you up-titrate the RAS inhibitor in this patient? And I'd like to point out some salient features for Emmanuel here. He has type 2 diabetes and hypertension. He is on irbesartan. That irbesartan dose would be considered a starting dose. The maximum antihypertensive dose would be about double that. And he does have a blood pressure that's not quite at goal and residual albuminuria. All right, so we're getting some answers here. They're starting to plateau. The majority of the audience is saying yes. There's also some no's and some unsures. So here we're getting into more tricky circumstances, and we'll go through the data here. All right, first, looking at the overall rubric here for treatment, Emmanuel is already on all of the first-line drug therapies. There's a caveat here, though, that if you'll notice for the RAS inhibitor in first-line drug therapy, it says at maximum tolerated dose. So what does that mean and why? We'll dive into that. The KDIGO recommendations do recommend starting a RAS inhibitor for people with chronic kidney disease and albuminuria who have hypertension, and titrating up to the highest approved dose that is tolerated. Why is that? Well, from seminal trials of RAS inhibitors in chronic kidney disease, first of all, those were conducted in people with albuminuria, and that's where the highest level of evidence for RAS inhibitors exists. And second of all, the protocol for those trials were to use the maximum tolerated dose. So our evidence for RAS inhibitors for slowing CKD progression is for RAS inhibitors with a maximum tolerated dose. Emmanuel here does have albuminuria. He does have CKD. He is an excellent candidate for a RAS inhibitor per these recommendations, and they would advise that it indeed be titrated up. It may also help some of those intermediate targets, including his elevated blood pressure and his residual albuminuria. I'll note here that albuminuria is key in the decision-making for patients who have hypertension, but no albuminuria. CKD progression risk is relatively low, and other antihypertensive agents can be used even for first-line therapy, but with the presence of albuminuria, RAS inhibitors are strongly indicated and should be titrated up. All right, this is our last poll question for the case discussion. So, would you initiate a non-steroidal mineralocorticoid receptor antagonist in this patient? And for this question, I'd like you to assume that you've titrated up the ARB already, and that his labs look similar with residual albuminuria, blood pressure near target, and a potassium in the normal range. All right, we'll wait for some answers to come in here. And our results here look fairly similar to what we had for the last question. I think the majority are saying yes, also with some no's and some unsures. So where do mineralocorticoid receptor antagonists fall into the treatment paradigm? They're here in this additional risk-based therapy. And it is important, as previously noted, to regularly reassess risk factors, including blood pressure, albuminuria, glycemic control, et cetera, in the care of patients with diabetes and chronic kidney disease to help decide on this additional line of therapy. And we'll zoom in on non-steroidal mineralocorticoid receptor antagonists, specifically for the care of Emmanuel here. KDIGO recommends in both of its guidelines, 2022 and 2024, we suggest a non-steroidal mineralocorticoid receptor antagonist with proven kidney or cardiovascular benefits. Right now, that's finerenone for patients, adults with type 2 diabetes, an eGFR of 25 mils per minute or more, a normal potassium concentration, and residual albuminuria, 30 milligrams per gram or more, despite maximum tolerated dose of RAS inhibitor. And that's given at level 2A level of evidence. So that's for many patients and a high level of evidence. And the rationale here is that two trials, Fidelio DKD and Figaro DKD, did demonstrate that addition of finerenone to a background RAS inhibitor did reduce risk of CKD progression, as well as heart failure and other cardiovascular events. In other words, reducing residual risk. Practice points indicate that residual albuminuria is indeed a very important factor in decision-making here. Residual albuminuria is a marker of risk of these cardiovascular and kidney outcomes and is what we can use to decide which patients should receive intensive therapies, including non-steroidal mineralocorticoid receptor antagonists. And another practice point, 3.8.2 here, noted that RAS inhibitors and SGLT2 inhibitors and non-steroidal MRAs, while not all studied together, tend to be complementary in mechanism of action and based on subgroup analyses seem to be effective. So Emmanuel is indeed eligible for treatment with a non-steroidal mineralocorticoid receptor antagonist. All right, Natasha, we went through those two illustrative cases. I hope they were useful. I think they illustrate some of the complexities and individualizing therapies and applying this as evidence-based medicine. And I hope we have time for some discussion.
Excellent. Thank you very much indeed, Ian. Thank you for that clear and interesting, thorough walkthrough, applying the guidelines in the case studies. So I'm just looking to see if we have any questions here in the box. Q&A. So we have a question here. So Ian, there's a question here to ask when to use antiplatelet therapy.
Great question. And I love that question in particular because it's not directly kidney related. We're, particularly as nephrologists, very concerned about reducing risk of CKD progression. It's very important. But cardiovascular risk is very high in CKD patients as well, and an equally important target for risk reduction. Antiplatelets don't affect kidney function. They can be used safely. They don't reduce kidney disease progression, of course, but they are important for secondary prevention of cardiovascular disease. So they work for people who have known atherosclerotic cardiovascular disease, for example, those who have had an MI in the past. There's uncertainty about whether to use them for primary prevention. So people who are at risk, as you could argue, both of these patients are at risk of atherosclerotic cardiovascular disease, but neither one was known to have it. Should they be treated preventively with aspirin? The evidence is not clear there. It does increase risk of bleeding. It may reduce risk of cardiovascular events. Those nearly balance. And so there is no official recommendation for primary prevention because the data really aren't clear there. It's a good and important question. Thank you.
Sure. Now we just have another couple of questions coming through. Now you did allude to this in one of the algorithms about when the practice point about being able to use SGLT2 inhibitors with an eGFR lower than 20. we've got a question here. What eGFR would you not use SGLT2 inhibitors in your experience?
Yeah, that's a great question. So I generally stick with the guidelines, and most patients with type 2 diabetes and CKD of any flavor who have a GFR of 20 or more, I will start. And increasingly now I'm expanding beyond diabetes and treating proteinuric non-diabetic chronic kidney disease as well, also with the threshold of eGFR 20 or more. That's based on trials like the EMPA kidney trial, which used 20 for inclusion. And then the question becomes, well, what about over time as these patients are treated? If they do progress, and many patients, of course, do still progress despite optimal therapy, what happens if their eGFR falls below that? I continue the SGLT2 inhibitor as long as it's treated. And there are observational analyses suggesting that's appropriate, and that's what the trials did. The trials that showed benefit did continue people on study drug, even if their eGFR fell. So I think that's the appropriate therapy. What to do when they reach dialysis, if they do reach dialysis, or kidney transplantation is another topic, and really an evidence-free zone. So hard to make good recommendations there.
Absolutely. There is another question that's once started on finerenone 10 milligrams. When would you increase it up to 20 milligrams?
Great. And Natasha, maybe the two of us can take this question. I think there are a couple of issues here. One is about the dosing of finerenone after you've determined a patient is eligible and appropriate. And then I think we should also touch on monitoring, which I didn't do to make sure we had time for discussion. Maybe I'll take dosing and you take monitoring, Natasha. Does that sound appropriate? Okay, good. So dosing, the trials that I referenced did an eGFR-based dosing. And so for people who had an eGFR greater than 60 to begin with, and albuminuria, which was their indication, they would start at 20 milligrams daily of finerenone. For patients with an eGFR less than 60, and these patients were all on RAS inhibitors already, maybe diuretics, et cetera. So there was concern that starting at a full dose may result in too much hemodynamic change. The initial starting dose was 10 milligrams daily. Labs were rechecked at a month or so, and if the potassium was okay, then the dose was increased to 20 milligrams. So I think I answered the question, the specific question, which is when would you increase? And I'm assuming that refers to somebody who started at 10 milligrams because they have an eGFR less than 60. I would recheck labs in about a month or perhaps longer. And if things look good, go up to 20 milligrams at that time. Important in that decision-making is potassium. And potassium management is something we do a lot of in nephrology and very important for NS-MRAs. Natasha, do you want to comment on that?
Yes, as you say, in the finerenone studies, there was a relative risk of hyperkalemia in terms of doubling the risk. And in order to mitigate that, the Fidelio DKD and the Figaro DKD trials actually has provided us with their protocols, have provided us with some guidance to monitoring for people with hyperkalemia. So the first thing is that in these trials, they restricted eligibility to patients with consistently non-elevated potassium concentrations after maximizing their doses of RAS inhibitors. And so the guidance that have been developed out of the protocol is that clinicians should use a similar approach in selecting patients who have consistency in their normal potassium concentrations, and then in treating the patients and monitoring the patients, there is protocol that is derived dependent on their potassium concentrations, and also there is that guides to when you hold phenarione back if there is hyperkalemia, and when that can be reinitiated if possible. And so within the guidance, both in the diabetes guidelines and the KDIGO Diabetes Guidelines and the CKD Guidelines, there are figures to guide clinicians how to monitor patients once initiated. Okay, so we have probably 3 more minutes left, so to answer questions. So can we use SGLT2 inhibitors in non-diabetic CKD patients? And I may just hint that this may be covered also in the next webinar as well, I suspect. But Ian, do you want to very quickly?
Sure. I see multiple good questions, so we should be quick. And the answer is yes. While we started with evidence in type 2 diabetes and CKD for SGLT2 inhibitors, it is clear that there are benefits in other populations, including people with non-diabetic CKD and proteinuria. There's high-level evidence. Without proteinuria, there's also evidence, not quite as high level. For people with heart failure, it's definitely indicated as well. So whether or not they have diabetes or CKD. So yes is the answer, but there's some complexities.
Sure. Excellent. What about risk of hyperkalemia as RTA for RAS inhibitors and non-steroidal in CKD patients already?
Yeah, and I think this is non-steroidal anti-inflammatory drugs, perhaps that's being addressed. So absolutely an issue, and you know, we should note that this really should be personalized medicine. Everybody's different, and there are lots of unique scenarios. Potassium issues can certainly limit both RAS inhibitors and MRA therapy.
Okay, and I think we've got time for one quick one now. When to use statins in diabetes?
It's a great question, like the aspirin question. And statins really are drugs to prevent atherosclerotic cardiovascular disease. People with diabetes and chronic kidney disease are at high risk. And the guidelines suggest that adults 40 years or older who have diabetes and CKD should be on a statin. And the dose of moderate versus high is determined by their prevalent cardiovascular disease and cardiovascular risk. But adults age 40 or more should be on a statin of one type or another. Perhaps some younger adults as well, but the data is more thin there.
Ian, thank you very much for your answers and addressing a lot of the issues that were brought up. So we are coming towards the end of our time for this webinar. We've had some interesting discussion on applying the evidence-based guidelines to support the holistic and patient-centered management of the risks associated with people who have diabetes and chronic kidney disease. The thorough review and new therapies, the thorough review of new therapies and high-quality trials needed to create the guidelines, create new opportunities for better treatment for patients with diabetes and CKD. So before we leave, excuse me, thank you. So before we leave today, I'd just like to highlight the 5th and final webinar in this series. This will be focusing on the management of the non-diabetic patient with chronic kidney disease, using a similar format to today, with our speakers being Dr. Rashida Hall from the US and Professor William Harrington from the UK. This will all be happening on the 22nd of May, and you can register for this on the KDIGO website, as you have done for the previous webinars. So before we finish, I'd just like to say thank you all again for joining us today from wherever you are, whatever time it is. Thank you to Dr. de Boer for a fantastic presentation and taking us through the case studies. And thank you to our sponsors and to Science Collected for all their hard work and dedication to the cause of moving along the messaging for people for the guidelines and outcomes for people with CKD. So if I could ask that you could scan, there should be a QR code. Thank you. That you scan the QR code to complete the survey. We'd be very grateful for your feedback so that we can help to make these sessions more centered towards your needs in the future. But in the meantime, thank you very much indeed to everyone for taking part and joining us today. Thank you.